Hello, everyone, and welcome to the webinar, My Secrets on How I Beat Kidney Cancer. We are live in Quebec City. We are attending the COAN conference, the annual meeting, a very successful day, and this is a really nice way of rounding it up with this webinar with Stephen Andrews. So why don't you tell us a little bit about you, Stephen?
Thanks, Lana. So, what is the communications for Kidney Cancer Canada? I am the executive director, but I'm also a patient. And I was first diagnosed in 2006. Washroom. I was at the time I was a journalist, TV journalist. I discovered that I had these little black things in the urine, and I discovered that they were tiny blood clots. And that's when we basically started the journey to find out that I had. The first thing that really happened was we dipped my urine at the local doctor and found that there was some blood there. Probably a lot of you have dealt with that. Then I had what's called a cystoscopy. That's a great situation, more or less, where they take a camera. I don't know who came up with that idea, and they put it on your penis and have a look into your bladder. So that was an exciting. And the doctor saw nothing with the neurologist. And then I went and had an ultrasound, and the ultrasound found a large tumor in my kidney, resulted in having it removed and my right kidney back in December 2006. And that was, by the time it was out, it was 14 and a half centimeters. And then following February, I had a chunk of my lung out because there was one spot there. And then the following April, there was a couple months later, there was metastatic disease all through my lungs. And that's when I went on a drug called sunitinib, and I took that drug 28 days on, and I took a 7-day break, and actually was taking a level of 50 milligrams, 28 days on, and 7 off. And one of the things that, one of my first secrets that I can tell you that I did is I took that drug at nighttime, every night before I went to bed. And obviously one of the big issues when we take these medications is that they do tend to affect us during the day. So and dealing with the side effects. And that was one of the things that I definitely did. I took the drug at nighttime, and I found that really helped. Dr. Knudsen, that practice actually is called metronomic, same time every day. So I took it at night every day. And
sorry, Stephen, I'm just going to say, somebody said that the words are cutting off. Is it just let me know through the chat if it's like this for everyone, if we're having an issue with our connection or it's an isolated situation?
Okay. And if it is, we have another mic that we can use here. So what I did is when I was taking the drug at nighttime, I was dealing. Coming happen?
Yeah, everybody's complaining.
So I'll tell you what we'll do. We'll put another mic in and see if that makes it better. One sec. Different color. How's that, everyone? Can you hear us now? Is that a better microphone? Just let us know. We'll just check our chat box now. There we go. That's better? Yeah, so it's another microphone. So I'll just quickly go back. I started taking sunitinib in 2007, in April of 2007. And I was taking it nighttime all the time, and I took it 50 milligrams on, basically 28 days on and 7-day break. And that was, I did that for 4.5 years. And then after 4.5 years, we saw a shrinkage. And I did have a met on my spine, but we radiated that with stereotactic radiation, part of what was then a new study in Toronto at Princess Margaret Hospital, and it stopped it in its tracks dead. So that was a good situation. And I kept taking the drug. And after 4.5 years, we couldn't see any evidence of disease. So I decided I was going to come off it. And my thinking was, if
it started to reoccur, then I would just go back on the drug at that time. But it didn't show up, and here I am now since 2011, latter 2011. I haven't been on any therapy, and I've been that way. And I do have regular scans, maybe once a year, maybe a little bit longer than that, and we still haven't seen anything. So that's my very brief story about my experience with kidney cancer.
So the webinar is called My Secrets. Now, are your secrets good for everyone? What is exactly what you want to share with everybody? Yeah.
So I do want to say that, you know, the expectation is, and I hope you haven't come to this with the expectation that by the time you hear what I have to say about my treatment with kidney cancer and some of the things that I did, that if you follow those, that you're going to end up in exactly the same situation, because as you know, all cases are different. Everyone has a different subtype of kidney cancer. Mine was clear cell. It had converted some of it into sarcomatoid when it was taken out, but that's basically what I had. So, but I do think that many of the steps that I took during those 4.5 years, and even today, helped get me through the challenge of dealing with kidney cancer. And also, I guess some of my secrets are going to be really what I dealt with you know, my partner, and what I did with my doctors, and things that I really, you know, I think I was pretty aggressive in treating it and demanding certain expectations.
And when you said that you took it in the evening, was that a decision that you took with your oncologist? Is that, like, how was that decided?
Really good question.
Yeah.
So I took it at nighttime because I had gone to a conference where Georg Bjornson, Dr. Georg Bjornson out of Sunnybrook Hospital, who's an amazing kidney cancer clinician in Toronto, said, you know, he believes it's important to do that, to take it at nighttime. He found his patients, you know, succeed. You know, it lessens, or you sleep through some of the side effects. So I didn't speak to my oncologist at the time, but that was a decision I took. And basically, as long as I was being compliant, taking the drug at the same time every day, and succeeding, you know, obviously on that course, which we call compliance in the industry. So as long as I was being compliant and taking it every day, I found it help. Now, I would say that sometimes I'd wake up in the morning and I'd feel absolutely crappy. But you know, I think that was when I would get into later in the cycle. But for the most part, I would say I worked full-time all the way through my treatment options. I even traveled to Haiti and did a couple of reports from Haiti 3 times during that time, and I didn't have you know, any real issues. I mean, I will say I'm an extraordinary, what they call an exceptional patient. I responded well to the drug, and we know that on sunitinib, you get a 1 to 2% complete response. A complete response meaning it works and there's no evidence of disease afterwards. And I know that I'm exceptional, but I also think that I took steps during the treatment that really, I think, enhanced my care. I think I became more educated about the treatment options that were available, and I advocated for myself like crazy. And that may sound kind of weird, but my first oncologist, for instance, after the first round of treatment that I had, I just didn't have confidence in what that oncologist was doing. So I went for a second opinion. And that's when I met Dr. Christian Kolmensberger, who is now my oncologist, and he's also the chair of our medical advisory board today. Wonder how that happened. But it really was a good opportunity to get another opinion, to find out if the treatment options that I was being offered by my first oncologist were appropriate. and I didn't think they were.
Mhm. Before we continue, I just want to mention to everybody that if you have a question for Stephen, you can put it in the question box, and we are going to say the questions, and Stephen will answer them as and when we're going through the webinar. And we do have a first question. So, somebody, did you have a nephrectomy?
I did.
Mhm.
I had what's called an open radical nephrectomy. That means the complete removal of the kidney and the tumor. As I said, the tumor was 14.5 centimeters when I had it taken out. And you know, here's one secret that I learned when I was in there. So it was on my right side, and whenever I would get out of the bed, I would get out of the bed on my left side, thinking, "Oh, I've got to protect my left side of my right side of my body, because that's where the skull was." And I remember an IV nurse coming in, and she was an experienced nurse, and she said, "What are you doing?" And I said, "Well, I'm getting out of bed." And she goes, "Let me give you a tip. It seems completely counterintuitive."
Oh,
Wow.
I don't know.
Big thunderstorm here in Quebec City at the moment. And she said, "Roll into the scar," which makes sense really, because if you're moving away from the scar, you're kind of stretching those muscles. But if you move into the scar, and that was one of a really great tip. And so, because we try to have that area very to treat it gingerly, but she taught me to roll into the scar, and you know, way less pain, way less stress on it, and actually it was a great tip. So I thank her for that.
Mm-hmm.
Yeah.
I want to go back to when you said you went for that second opinion. Now, I know you.
Yeah.
You communicate well. You know, you have a strong personality. You're not timid. But what would you say to how can a person that doesn't feels that it would be difficult to bring that conversation when they're present oncologist, and not that they want to change, but they want to get that second opinion. Yeah. How would you say, how should they go about it?
So we were talking to a patient earlier today. Yes. And talking about that, and the patient responded, "If I do that, I won't be liked." Yes. Okay. And I said, you know, what do you want? And I do apologize if this sounds offensive. It's not, but it's a cold, blunt fact. I said, "Do you want to be liked and dead, or do you want to be alive?" And I think, you know, we have to get over that hurdle. And, you know, we can, I think at Kidney Cancer Canada, we've spoken to many people where we've talked them through it. There are ways to do this without offending your doctor. But I think any doctor, really, any clinician that's offering you treatment, if they're saying, you know, you don't need a second opinion, or, you know, I'm offended by it, really they're not, I believe, watching out for you. And I think that it's fair to ask for a second opinion. It's your life. You want to be confident that the treatment that you're getting, you're comfortable with that treatment, and that you're getting the correct treatment. And definitely if you're in a smaller center, sometimes the advice you're getting may not be as good as, say, somebody that's seeing 40 or 50 patients every couple of weeks that deal with kidney cancer. You know, I mean, I found that myself. It's like, you know, when I started in journalism, I mean, you know, to write the first 2 lines of a story were tough. You'd agonize of it. Well, you know, within a couple of months, you just sit down on the computer and you start writing, because there's just this inherent muscle memory that's going on, things that you just inherently know. So I guess that's really a good secret is, you know, be confident with your clinician, and get a second opinion. I always say second opinions can save your life. Don't be shy, don't be timid. If you feel you need it, if it's going to make dealing with your kidney cancer better, I would go and ask for a second opinion. There should be nothing wrong with it, and any doctor worth his weight or her weight will totally agree to it. I mean, all the doctors that we work with always say the same thing. I have no problem with that.
Yes, that's true. And so I heard you say, and that's the first time I heard you say that when you were on Suiton, you were still working.
Yes.
Yeah, so you were able to continue that.
Yeah, and you know, I know that I've heard many people have bad reactions when they go on a drug, and I guess I was lucky. I mean, I did have side effects. I mean, all my hair turned completely white. I mean, everywhere, my eyelashes, my eyebrows, everything turned white. And being on TV at the time, that wasn't a great idea. So I became very familiar with Miss Clairol. And the other thing I did is I always laughed at it because my mom would watch me on TV from miles away, and she would always come and she said, you know, no one would know you've got cancer because you look so good. And I'm like, you do realize I'm wearing makeup here on television. So she goes, even under the makeup, I can tell you good. But I think a couple of things I did. So one, starting in 2007, when I went on the drug was in 2007. I started going to acupuncturists, and since then I've gone every week. Now, I'm not saying that acupuncture is a treatment for cancer. We know that scientifically it's a treatment for pain, so it can deal with pain issues. So I did have severe issues with my mouth, that hot drinks or really cold drinks I couldn't have, pop I couldn't have because it would play havoc with it. I'm a vegetarian. I was before, and so I wasn't eating meat and stuff like that, but I had to watch staying away from tomatoes and acidic fruits and such. Even ice cream, if I wanted some ice cream, it was a bit of an issue because it would be so cold, my mouth would be sensitive to that. So I've often wondered if the acupuncture did kind of lessen some of the pain effects of some of the treatment. And definitely, I would say that I was able to tolerate the drug. Going through the cycle of it, what I would say is, you know, week one, yeah, a little bit of discomfort. Week two is a little worse. And then as I got up to week 3 and 4, it would get more intense. And in 2006, the same year that I was diagnosed, I ran my first half marathon. I thought it was only a 10-kilometer run, a little different. I found that out, you know, after I'd said, sure, I'll do this. And I looked at every single drug cycle as a mini marathon. And I would say, okay, you're going to go one more week to go, and then you're going to have a week off, and then you'll be able to have that food, or you can have a decent cup of tea because I love my tea. And so that's how in my head, it was like I was training. My only job at that time, in my mind, was to get on this drug, take as much of it as I could, as frequently as I could, and just load up the body, because we do know that with a drug like sunitinib, or Sutent as its brand name is, we know that there's an efficacy response with the intensity and also with the frequency of taking the drug. So that logically I knew was a good thing.
And during that period, how was it at home? Was it difficult time with your caregiver? How did your caregiver give you support, or was trying to? Yeah.
Well, you know, he did, and it was amazing actually, because it wasn't a journey that I did by myself, and I always wonder what it would be like to have gone through that alone, to not have somebody there. I mean, he was the one that said, you need to go get a second opinion, because this is just not working out for us. So I went and got a second opinion. And we walked around at that time with this big file, this binder of all the tests and everything, so that whenever anybody said to us, oh, well, we would schedule for this test, but we need to get blood work right away. Out come the blood work out of the file. There it is. Or, you know, I need an x-ray. Here's the latest x-ray. And so that's the kind of thing that we did. And you know, we would talk about the treatment options that were available, making sure that things were there. He would also look at me and say, we got to go to the hospital. And I go, why? And he said, because your eyes are turning a little bit jaundice from the drug. And so I would know that, you know, I'm going to come off it. We went once, and from then onwards, I just stopped taking it. Called my oncologist and said, yeah, I'm getting a little jaundice. Go get some blood work, and then we'll look at it, you know. But it was a tremendous support. So anybody doing it by themselves, I think I would say get a buddy or call us, and we'll set you up with peer support, because I think that's a good way to do it and talk through. So, you know, that is another secret that I would have, that get someone to go on the journey with you, someone that is supportive and someone who is understand. But, you know, be aware it can take its emotional toll, and it did take a toll on our relationship during that time. And it's like every day getting up, not knowing what tomorrow is going to bring. I remember going on a vacation once, and in 2009, and he wanted to go in September and I wanted to go in May, but I didn't want to say why I wanted to go in May. And so he kept saying September, and I said, I'd rather go in May, I'd rather go in May. And then the end, he cottoned on and he said, you don't want to go in September because you think you're not going to be here in September. And I said, yes. And then what happened is he said, I get it totally, and we ended up going.
Okay, just want to make sure that I'm not missing any questions.
Just going to go through some questions here.
Okay.
Here we go.
So what was your treatment the result of a recurrence of cancer in the remaining? Why can't we see it properly?
Okay. Got it?
Can this be, why isn't it opening? Hold on, Stephen.
Yeah.
Sorry, technical problem. Just gonna get.
We'll get there.
Okay, there. Can I make this bigger? Because it seems that the questions are chopped.
Yeah.
How did the second opinion differ from the first opinion?
Good question. Great question. Excuse me. So when I started taking the drug on my first dose, I was taking 37.5 milligrams of sunitinib, and it was going to be 28 on and 14 days off. So at the end of the first cycle, towards the end, I think maybe I was 2 pills left. We went in for a checkup with my first oncologist, and my first oncologist started freaking out that I had a sore throat and I've got to come off the drug. It's not going to work. Well, to us at that time, that was crazy. I mean, here was hope with this drug that we could treat the kidney cancer, maybe even cure it. Weren't thinking of a cure, but at least maybe manage it, control it, keep these little nodules in my lung, keep them the same. So when she left the room, what my partner actually said to me at the time was, Stephen, because there were also a couple of, I'd reported some pain in certain areas, and she ignored that. He said, when she left the room, he said, Stephen, I want you to go get a second opinion. This woman's going to kill you. So I asked for the second opinion. And that's when Christian Kolmansberger gave me the review. And he was, when we told him I was on 37.5, he said to me, interesting. And I said, interesting as in a good interesting, or interesting as in you wouldn't do that? And he said, I would never criticize another doctor's treatment plan, which is absolutely true. He doesn't. So I said, okay, let me ask the question another way. If you were my doctor, what would you do? And he said, I would prefer to have you on 50 milligrams, 24 days, 24 hours a day, 7 days a week, 52 weeks a year, but that's not possible because we know there's an efficacy issue. So what he did was he immediately prescribed. So I said, well, his pager went up. He left the room, he came back in and said, I want you to treat me. So I was in a major center in Toronto at the time, in Vancouver. So he took me on as a patient, and that is when we upped my dose and we increased the intensity of when I was taking it. So that's when I went from 37.5 milligrams, 28 days, 14 days off, to 50 milligrams, 28 days on, 7 days off. So that was a big challenge. And so really, other than my first cycle, I was on a 50 milligrams on a regular basis. And now I think about it, that's a really good question, because I remember saying to my first oncologist, you can take me to the verge of death and back. Let's get aggressive with this. And I remember the look I got, and it was kind of like you don't know what you're in for type look, or you say that now, but you don't know. And I think the impression I got is you didn't respect me as a patient, wasn't listening to me as a patient, because really, even though I knew that I may have limited time on this earth, I wanted to give it the best chance I got. And if it meant that I was going to get really sick, and I wanted the drug to do as much as it possibly could. So that's how it changed the treatment. And I would say I had a way better relationship with my clinician, my oncologist that was treating at the time. And I felt more confident in what we were doing. So that's how I think it changed the treatment. I hope that answers your question.
Was your treatment the result of a recurrence of cancer in the remaining kidney?
No. So right from the beginning, it was contained within one kidney, although it had moved to the lung. And I did have that lesion on my T11 on my spine. So to date, touch wood, there's been no reoccurrence. It was discovered as an original cancer site.
And if you need a second opinion and your urologist or oncologist will not provide it, can you get it from your GP?
All right. So yes, is the quick answer. But you've got to go to the right person. So there's, again, as I said at the beginning, any clinician that refuses to offer you a second opinion elsewhere, I really want to question whether they should even be in the business. But, I get into trouble for saying that, but I think you have the right to expect a second opinion. Yes, go to your GP. And if your GP doesn't know who to refer you to, give us a call, send us an email. We frequently can make suggestions and can schedule in that. So yeah, if you're having a challenge getting a second opinion, give us a ring and we'll help you through that.
So would you consider being stable on Sutent or any drug as working?
Yes. Simple answer. As long as it's not progressing and you can manage the side effects of the treatment that you're on, I would say that that's a step in the right direction.
Can this be done without your doctor knowing about it? What is the disadvantage of doing it the way medical reports? I'm not sure what.
I'm not sure. Maybe you could clarify that. I'll try to reinterpret your question. You're saying, can you do a second opinion without your doctor knowing about it? There again, we're going with this idea we do not want to offend the doctor. Okay. And I need to be blunt and say, it's your life. It's your life. Do you want to leave this world with regrets, or do you want to give it the best chance? And to be honest with you, and I know not everyone's like me. I mean, you said that
Mhm.
outgoing, but you know, give us a call. We'll talk you through it. And but if you feel you need a second opinion, go get it, is what I say.
Mhm. Are you encouraged by the research on kidney cancer in Canada and elsewhere in the world? And what are
Yeah.
the new treatments that are accessible?
Wow. Well,
Mhm.
we'd be here longer than 6
Yeah.
o'clock if we went through those.
Yeah.
But at the time that I went on to therapy, there was really only 2 drugs that you could have, Sutin or Nexabar. But, and I said there's 1 to 2% response. Now, with the standard, and that was the standard of care for many years. Now, the standard of care for poor risk and intermediate risk patients with metastatic disease is Ipi/Nivo or ipilimumab nivolumab combo, an IO combo, immunotherapy combo. And there, a complete response is about 10 to 15% of patients that go on that get about a good response. But you get good containment even on just nivolumab. And what I would say is I am impressed with the research because we are seeing greater response. We've got more therapies available to us now, and even the surgical options. We're doing partial nephrectomies, robotic nephrectomies. We're doing cryoablation where we freeze the tumor, and many different options. So yes, and at Kidney Cancer Canada is one of the reasons why we've been pushing so hard to raise money for new research projects, because Canadian clinicians, I'm telling you, they're exceptional. They're considered leading the world on their dosing strategies. Again, I go back to Georg Bjornson at Sunnybrook, and Dr. Kolmensberger in Vancouver, Dr. Lalani in Hamilton, and Dr. Ott in Hamilton, Dr. Wood in Halifax. There are a number of doctors across the way. I've missed people, but anyway.
We've got a big list.
We have a big list. Just trying to go through the pictures in my mind. But, you know, yeah, I'm very happy. And I'm seeing some great information coming out of them. And it's why we've been supporting more research. I mean, last year we managed to basically, with the donation, with the funds that people gave us, and leveraging that money with matching grants, we upped impact on research to $310,000. That may not seem a lot, but in the world of kidney cancer, trust me, that's a lot of money. So far this year, we're at $265,000. So yes, I'm thrilled with the research that is coming on, and there's some very exciting research coming down the pipe, and there's some new drugs that are coming onto the market, and they're going to be available for us in Canada. So yes, I love research. And by the way, research happens because of clinical trials. So a couple of tips more that I'm going to give you here is, if you are having a kidney removed or part of a tumor removed, always make sure that that tissue is, because otherwise they'll throw it out, make sure it goes into the tissue repository bank so that they can use it for testing, for research down the road. That's really, really important. The other thing is, make sure that you are signed up as part of CKIS, the Canadian Kidney Cancer Information System, because that data that you generate just by the treatments and your success that you're having can then be used aggregately. We can put it together and try to find new ways of treating. So make sure your doctor has you signed up on CKIS, the Canadian Kidney Cancer Information System. And the other thing I would say is, get involved in clinical trials, because the standard of care is really huge if you go on a clinical trial. And you don't have to take a clinical trial right at the end of your cancer treatment, like when you think it's a last resort. You can start a clinical trial even before you go on any kind of treatment or surgery. So there's always options open to you. And if you give us a ring about that, we can put you in touch. And the same with CKIS as well. Love to hook you up with CKIS, because that information is really helping patients.
Heather would like to know, well, she would like you to explain more about the lung nodules and what were your symptoms.
Okay, so, excuse me, I'm just putting my drink. I'm not drinking Ryan Coke, by the way. I wish I was. I should have been after the past date getting here to come here. And I apologize. Normally I'm in a suit, but I kind of lost my luggage for some reason. And apparently I'm going to live out this conference in a black t-shirt and jeans. But anyway, the symptoms, I had no symptoms in my lung whatsoever. When we scanned, when they scanned me, the kidney, the first thing the urologist called me and said, "Hey, we've had a bit of a, we think we caught something on the scan on the lower side of left of your lung." And the other thing he said to me was, "And I need for you to go for a bone scan." And I was like, "Why bone scan?" He goes, "Well, one of your blood tests came back that indicated that you had a high alk phos level, and that could be a sign that you had that's invaded the bone." Well, I mean, you can just imagine how that went over on that Thursday. And so I went for another scan, and all we could see was one nodule. And at the time, my first oncologist sent me for a PET scan. Now, I'm going to step outside of that for a moment. If you're being sent for a PET scan, ask your doctor if it's really necessary, because it's not, in kidney cancer, from everything I'm hearing from the clinicians, it's not a great thing to do. So that's something I would consider. The bone scan I had came back totally fine. So that's all I had. So I took that out. We took that out surgically, and I was up for another couple of weeks work at that point. And then when we discovered the lesions all the way through my lungs, again, it was found through a CT. It was not found from anything else. And that was, I never had any pain, breathing issues. So I know that some patients do get that when they have mets in their lungs, and that is controllable. So I'd say speak to your oncologist about that, and the steps that they can take to deal with that.
Now, Karen clarified the question, but I don't know if it's any clearer. In order to do this without the attending doctor's knowledge, how would you be able to provide your medical report?
Okay. So again, Karen, if I haven't interpreted your question correctly, let me know. So one thing that we found right at the beginning is we got copies of every single report that was there. And the hospital, you own that data. And so you just simply go to the Information Privacy Office and you can get a copy of that report. So you can have your reports in your hand, and you should ask for them when you're getting, when the doctor's getting a report back from blood work. When you're going to get blood work, make sure they copy you at home. When you get a radiology report, ask for a copy. And, you know, I mean, and if they say, well, you know, it's photocopying, let me show you. This is a great tool, right? And I've got an app on here where you just can kind of go in there and snap a picture of a page and it turns it into a PDF. So you're entitled to all your records. So I would say ask for them and keep them in a file. I think it's a great idea. And then, you know, if you're going to go and see someone else, you can kind of show them if you don't want the reports sent to another patient, another clinician. Okay. Does that kind of answer your question? I hope it has.
Eve is asking, how long were you on Sutent until you were no evidence of disease?
4.5 years.
At what dose and cycle were you on at the end? Did you take yourself off?
Yes. So the answer is I was when I was on 50 milligrams, 28 days on and 7 days off. Now, I will acknowledge that when I got to the end of some of the cycles, it just, I felt so tired from it that I said, well, I'm not going to take the last pill or maybe the last 2 pills. I tried, but more often than not, I did. And then I did I would take myself off the drug for the 7 days and then start the sequence again. At the end, what happened, we couldn't see anything in my lungs or anywhere else on my body. And I remember Dr. Kollmensberger saying at the time, he said, well, we're in uncharted territory here. And I said, what does that mean? He said, well, you could, I mean, the decision is, do we keep you on the drug or do you come off the drug and then we see if it grows again? So I don't know why I just made that decision myself. And I just took myself off the drug at the end of it. And I didn't see anything. And probably it was a good few months. And I just happened to be giving a speech at a kidney cancer patient conference. And I announced to the audience there that my oncologist was sitting in the front row. And by the way, I've been no evidence of disease for now a good year, and 6 months of that with no therapy. And then I heard my doctor say in the front row, what? And I was like, oh yeah, I forgot to tell you, I stopped taking the drug. I do not advise this, okay? Like now in my position as the executive director of Kidney Cancer Canada and a kidney cancer advocate, I do not advise it. Tell your doctor what you're doing. But it hadn't come back, and I did know that I was going for monthly scans, Eve. So I knew that if something did come up, we'd say, oh, it's starting to grow. And then I would come clean and say, well, actually, I came off the drug. But as I said, touch wood, nothing's grown.
So John would like to know if the side effects changed over time for better or worse.
So they were pretty consistent. I mean, my hair turning white, I wouldn't say that that's a terrible side effect. That's a vanity side effect. When I would get sores on my tongue, that was bad. Sometimes it would be awful, and sometimes it would be okay. And it did affect my appetite. And I mean, we'd have breakfast in the morning, and he'd say, "Do you want breakfast?" Sure. And I did at that point until it got put down in front of me. And I don't know if you guys have ever dealt with this. And then I'd be like, "I can't eat it." And he'd get so mad at me. He'd go, "Just try." And I went, "I know I can." And he'd get mad at me and he'd say, "I know what you're going to do. In a couple of minutes, you're going to go into the cupboard. You're going to get a sugar cereal out. You're going to have some of that." But that's all I could do at that moment. And that was to get a Sugar Crisp, which I always liked as a kid. So maybe it was a comfort food as well. And I would load it up and I would pour milk on it and it would become mushy. And then I would literally I would just put it in my mouth and suck the milk and the sugar out of it and then swallow it down because it didn't hurt. And so that, and I remember Danny going with me one day, and he says, and he tells Dr. Kollmensberger that this is what I've been eating. And Dr. Kollmensberger just went, at least he's eating. So, and I not recommend it. I mean, you should eat a healthy diet. But the one thing I also found out is that if someone was cooking for me, do not be in the house when they're cooking. So, maybe they can text you, go outside, go upstairs where you can't smell the food, and then sit down and then make an attempt at it. And I think that's a great tip that someone offered in a conference years ago. And that's one secret that I would say. So I did manage to keep my weight up during when I was on the drug.
We have a question from Jackie. I had a radical nephrectomy 25 years ago and now have what appears to be renal cell carcinoma in my remaining kidney. What treatment options are there for a recurrent renal cell carcinoma?
Well, I would say, so this is recurrent, so it's really, it's going to depend on how big the tumor is and where it's located. So I don't want to dispense medical advice, but from what we have seen and what we have heard, that there are options, and partial nephrectomy can be used in that situation, or they could try a systemic therapy. So I'm going to leave that question up to the oncologist and the urologist, but definitely I would say get into somebody that knows what they're doing, a really good surgeon first maybe, or go and see a good oncologist. And if you need some suggestions, again, give us a ring or send us an email to info@kidneycancercanada.ca. Mona myself will work something out for you. Okay.
Mhm. A question from Jim. Did you have any problems keeping your weight up? And if so, what did you do to counter weight loss?
So I was lucky. The weird part about this, Jim, is when I at the beginning of 2006, with the year I was diagnosed, the station came to me and they said, "Would you do this marathon?" And I was like, "Okay." And they said, "And we'll help you with it. We'll make sure you get a trainer. We'll get you a gym membership, and we'll train you to do this." And I was like, "Oh, sweet." So here I was working out 3-4 times a week and getting toned, and you know, I was good and losing the weight. And I'm thinking to myself, I'm losing this weight. I'm doing a great job. Of course, what was going on during that time is I was also losing weight due to the disease, which was a challenge because obviously if I'd just been my normal regular self, eating and losing weight, I would have known something was wrong. On the drug itself, I would say that I just tried to eat whatever I could. Baked potatoes with butter. That was a food that I could eat. I could mash it up and eat it down, and I just tried to keep my food intake in. And I think my partner also worked as a coach in my eating, and that sounds a bit weird, but you know, going, you got to eat something, you got to have something more. Let's try this. That's not enough. And eventually we came to an understanding there's more enticement of foods that I would eat. So, you know, I like shepherd's pie. So we would make a vegetarian shepherd's pie, and we wouldn't put salt and pepper in it. We would just make it as bland as anything. So foods that really I liked and spoke to me, and you know, it made me feel happy, comfort foods. That's how I would do it, you know.
Yeah. After an open radical nephrectomy, I have been clear for 6 months. Are you aware of preventive measures to prevent metastatic recurrence?
Okay. It'd be good to know where you're located. So with breast cancer, we have what we call adjuvant treatment. And they're in the States, they have adjuvant treatment. So what they would do is they would give you a year's, they would do the surgery. And the thought is in adjuvant treatment is that if we continue to give you a drug, or we give you a drug that we would normally treat metastatic disease, that could kill any remaining cancer cells. And you've heard this in definitely in brain cancer, definitely in breast cancer. And that's what we're looking for in kidney cancer. There's been some trials on sunitinib, bosutinib, and the evidence doesn't appear to show that that is a good option. But there are some new trials coming out now, and some trials running where you can take an IO therapy or an IO-TKI targeted immunotherapy and a targeted therapy combo. My advice to you is check our website for the latest up-to-date list of clinical trials, and speak to your treating physician to see if there is a clinical trial that you can go on that may be in the adjuvant setting. And if that is all confusing to you, again, give us a ring. We'll help you out with that.
So Karen says, yes, we did answer her question.
Great,
and
that's good.
And she has another one. Do the side effects over time get better, or do you learn how to manage them more?
I think I learned to manage them more from my experience. And, you know, that baked potato and butter thing was a great thing, because when I was a kid, I had really bad tonsils and that. And my dad used to make me, believe it or not, mashed potato sandwiches. So just bread and butter and then mashed potatoes, and I would be able to eat this. And it was something I could go down. So I've always kind of, you know, potatoes, it sets off this thing in my mind that that's a good, and it's high in caloric count as well. But the butter was smooth, and the potatoes, you know, would go down. And you know, I'm being honest, I would like suck the butter out of the potatoes because it made it feel good. And so I think that you do find ways to manage them. I personally never had good time with what they call magic mouthwash. The other thing I did is I changed my toothpaste. I couldn't have regular toothpaste. It used to make my eyes water, and I would have to brush my teeth, believe it or not, in breaks. At first I would brush a little part of my mouth, and then I would rinse it until I could recover from the menthol there. So there is a toothpaste you can get at health food stores called Wallenda, and again, we can help you with that. And it was a kind of a liquish taste to it, but I could brush my teeth with with this toothpaste, and it would work, and I could do it all in one go. So yeah, that's a typical thing I would do. Moisturizers, and drinking water. I avoided coffee like the plague during that time, because that would upset my stomach even further. So yeah, there are steps that you can take to lessen side effects.
We've got a Karen, RFA for a new primary up to 3 centimeters also available. I just had it 2 weeks ago. I guess that's a comment.
Yeah, radio frequency ablation, RFA. Yes, and again, ask your doctors when you're going in there, am I a candidate for cryoablation, radio frequency ablation, or is surgical the only option? Or can I try stereotactic body radiation therapy? Ask what options are available. And then if they say, this is what we have available, say, okay, that's what you have available here and now. But what about outside of the geographic area that we live in? If you're in British Columbia, say, are they doing any studies in Toronto that I could be referred to? So sometimes you have to be a little bit flexible. And there's a big feeling, if you go down to the States, you're going to get whatever you want. There's many, many options. I mean, when I had the SBRT, the stereotactic body radiation therapy, I did travel to Toronto because it wasn't available in Vancouver and Victoria at the time. But thanks to another research project that we've just kind of got involved with, yes, we're expanding that. So yeah, find out what's available outside of the scope, and that might be able to help you.
Another question from Eve. How true is the idea of the efficacy of the drug is based on the intensity of your side effects? The more, the better. I've gone now, I have none after 3, except showing in blood work.
So all I can tell you is I've spoken to clinicians about this, and they tend to say the same thing, that they do want to see side effects because they know that the drug is working. But that doesn't necessarily mean that if you're not getting side effects, that it's not working. So that really is, I think, is an individual case. And again, it's something you should talk to your clinician about. I do know that we in the industry like to see giving you maybe over medicating a drug to try to bring on those side effects, because then we know that you're getting some reaction to it. So I would say that, again, a question you should talk directly with your oncologist about.
Jim is asking, from your perspective, if one's disease is stable, is the rule of thumb to stay on that medication until it no longer works?
Yes, I've heard my doctor say many times he wants to leave you on you're only going to have so many lines of therapy that's going to be available to you. And I think one of the things that you need to consider, you need to stay on the drug as long as you possibly can. And as Dr. Kolmensberger says, squeeze every last drop of usefulness out of that drug. So yes, stay on it as long as possible. Again, consult your clinician.
So that was one of the last questions. So keep them coming.
Yes. Okay. Thanks. That's a great number of questions. Yeah. And there's a lot of you joining us today. And while we just wait for some more questions to come in, first of all, we should check the time because we're not doing that. Oh, well, we got 6 minutes left. So we'll get as many questions as we can. So we're here in Quebec City because every year the Canadian Urological Association holds their annual meeting. And this year it's in Quebec City. Next year it's going to be in Victoria. So I only have to travel 8 minutes to the conference next year. So it's a full day this time. But it's a great opportunity for us to network with other patient groups. Great opportunity for us to do outreach to the clinicians as we've been doing. And a couple of things we should talk about the genetics project. So what you will find online, we set up a new page, kidneycancercanada.ca/genetics. And here at the conference, we've launched this new brochure that we've been working with Dr. Raymond Kim and the Kidney Cancer Research Network of Canada, also the Canadian Urological Association and the Canadian Genetics Association. And really it starts talking about when is appropriate to have genetic testing and when might you not need it. So that's going to be up on our website very, very shortly.
I'll put it up at the latest tomorrow morning.
Tomorrow morning. So we'll have it there for you tomorrow.
Yeah.
But it's a good read. You should read it. It'll tell you a little bit more about what's going on.
We've got 2 questions.
Okay.
Would revisiting a drug be considered another line of therapy?
Possibly it could be, depending on the payment. And we call that re-challenging. And I would again speak to your clinician about that and find out what's going on with it, with what payer it's going to be, whether it's a public payer being a government or private payer being an insurance, or even sometimes out of your own pocket. But it could be another line of therapy, could be considered, but it just depends on, again, sometimes how creatively it's submitted as well, to be honest.
Heather, what is the standard for surveillance in CT scans after radical nephrectomy? And is it harmful to have repeat CT scans on the remaining kidney?
Okay, so again, I'm going to talk to you about my situation. I was going for scans every 6 to 8 weeks during that. And I remember going in one day and my partner saying to Dr. Kommensberger, with all this radiation, this scanning, is that something we should be worried about? Because he was like, well, technically, yes. But he said, you know, scans are the least of your worries at the moment. You know, he said, speak to me in 15 years time. Well, we're 2006, 2019, we're getting up to that, you know, that should I be worried about that? So it depends at what state your disease is. Again, I would talk to your oncologist about it, because when I had that conversation with my oncologist, we did adjust the schedule. So there was always a risk of you know, too much scanning, radiation scanning. I would have a chat about it. If you're concerned about it, you know, maybe you could talk about other options that maybe less fractions, maybe like a ultrasound of the kidney area, maybe a chest X-ray. But again, it's a kind of a difficult question to answer without knowing what the status of your disease is and where you sit right now.
Okay, what do I need to do in order not to recur my kidney cancer? Being diagnosed stage 1, grade 2, clear cell RCC, partial nephrectomy. I am not taking any adjuvant therapy. What food or things I need to eat or do?
So we had this the other day on the day of Kidney Cancer Talk. I don't think there's some people concerned that if you are in a if you are taking sugar into your diet, or if you tried to turn yourself alkaline, that this could prevent it. Nonsense, nonsense, nonsense. We know there's no evidence now on sugar being, you know, some cancers feed on sugar. We know that that's not an issue. In alkaline, you'd have to really go some to make your body alkaline. I would say eat a healthy diet. Look at the Canada Food Guide. But also, you know, maybe a keto diet is something that you would want to look at. But be sensible. You know, go on a diet that typically diabetics should be having. You know, keep your weight down and just be aware. But also note, though, if there's no sign of disease, and depending on the size of your tumor, that the guidelines, and you'll find them on our website. Where were we looking at today? The surgical guidelines.
Yes, so it's under patients and caregivers under the menu, and it's kidney cancer treatment guidelines, and you'll see it's the second guideline up on top.
So it's a good thing to be aware of how often you should get imaging. And the imaging does not mean CT scan, but definitely you need to be vigilant on that.
Mhm. So Samuel said that he thanks you very much,
Thank
but
you.
the sound was quite bad for him. Would it be? Yes, we will be posting this on the website, and hopefully the sound will be recorded as not the way he hears it.
We'll check. We'll check. too,
Yes.
as well.
Yeah.
But Samuel, if you do have questions, please send them in, and then Mona will forward them to me, and we'll get you some answers. So if there's something that you specifically didn't hear, let us know, and we'll get back to you on that. Okay?
Mm-hmm. So Eve is saying thank you to Mona and Stephen. That was
Thank you.
amazing. And Ian said, no question, but wanted to thank you for the webinar. Very interesting. Karen has a question. I was once told by a medical professional that if a patient is overweight, overweight, obese, an ultrasound would not be effective. A
Yes,
scanning
true,
method.
true.
Okay. Whoops, sorry.
That's true.
Yeah. I think I've lost it. I'm sorry.
We'll go looking for that.
Yeah.
So that is a true statement. Yes.
Yeah.
And you know, I struggle with weight issues all my life. So what I would say to you is, if you are, and let's be honest, you know, I mean, I've got a bit of a tummy now. It's not good. We know that being obese or overweight is a risk of it puts you at risk of kidney cancer. So, and so does diabetes, and so does being tall, believe it or not. That's why Mona is never going to get kidney cancer. She's way shorter than me. But you know, yeah, it is an issue. So you should look at the risk factors that are there and work on them. And again, speak to your doctor, see if he or she can give you some help in getting your weight down. You know.
So we're getting many thank yous from
Wow.
Karen, thank you too, and then Yves who's saying merci beaucoup pour votre implication à vous tous. Yeah, and Ian, that we always learn something from the webinars. Thank you so much.
Hey, listen, we love doing these because to engage with you, we wanted to do something from the Canadian Urological Association. So send us an email, would you please? And also post up on Facebook to let people know how you view them, maybe topics that you want to see. Yes. We would love to know that, because we'll go find them, the people that can speak to it. And if you enjoyed this kind of chat, we can schedule more. If you think it would be of benefit, just let us know, and we'll make sure that we do.
Yes,
it.
Absolutely.
Yeah, absolutely.
I had fun.
And it's a pleasure. It's a pleasure speaking to you. And you know, our goal is to improve the lives of those in Canada, and actually even around the world, whose lives have been touched by kidney cancer. And it's an honor for us to work for you and to help you. We get up every day with a smile on our face. I tell you, I love my job, and I love the fact that we can engage, and also the tips that you give us too. We can pass them on to other people. So we're going to leave it there, because believe it or not, we have some other things we're going to do. We will connect with you again very, very soon. And I also want to point out two things. One, we got a new website coming.
Yes.
I'm so excited about it. I've seen it, and I'm telling you, I'm thrilled. It looks good.
Yes, it does. Okay. It does.
We're just fixing the bugs. And the other thing I want to tell you about, we're also going to have a new chat forum on that. So we'll launch the site, and then after that, we're going to put a new chat forum up, and that's going to be a big thing as well. Okay. So thank you, everybody. Have a great night wherever you are, and we'll see you again very, very soon. Thanks for joining us. Good night.
Thank you. Good night. I'm having trouble.